Uganda. RHU is an organization that is focused on advancing access to sexual and reproductive health across the entire country. I'm based in Kampala, but we have branches, very many, even in Fort Portal. I'm pretty sure Kaihura is not far from Fort Portal. In case you need our services, you can chip in there. This evening, we're going to talk about a topic that is very important to almost all of us, and the subset that this is something that we usually ignore. One thing we need to admit is that in Uganda, most of the pregnancies come in unplanned, especially the first pregnancy. People just realize that, oh my God, I think I'm pregnant. No planning, nothing. They're not sure about the people that they're having their babies with. They're not sure about their sickle cell status. They're not even perhaps sure about who the daddy is. And that's why it is very important to have such discussions like the one we are having this evening, because it's for us to plan for the future, to plan for the babies that we're having, but also to ensure that in the process of parenthood, we do not have any regrets along the way. So I don't know how many people on this call are parents already. I don't know how many are planning to become parents soon, but what I'm pretty sure of is literally everyone on this call is going to be a parent at one point, apart from a few maybe who might be disadvantaged by nature, and those who might choose not to have by choice, maybe. Yes, usually when you're going to get married to someone, you want to make sure if you're compatible with this person. So you look at a number of things to assess that compatibility, which range from social cultural compatibility. So we've had scenarios where people from maybe one tribe do not want to marry people from another tribe. Yeah, it is very common. So they're looking at that compatibility, because sometimes the cultural norms differ, and someone feels like, me, I cannot do this, which is being done in another tribe, so they can't tamper going that side. You guys, when you're growing up, you used to hear about Muria Soka eating the first baby. I don't know if that thing was real, but yeah, you could be like, no, I can never marry in the Muria Soka. Then you look at religious compatibility. We've had cases where, for example, people be like, I cannot marry someone who is not a Muslim just because I'm a Muslim. Or even the parents themselves be like, for me, I want a Catholic. If the man is not a Catholic, please don't bring them at my home. We look at the emotional compatibility, and that's why you spend time in the dating stage, getting to know each other, getting to bond, getting to connect. We look at the physical compatibility. You must definitely be compatible with the person that you're getting engaged with or involved with. That person must be physically attractive to you, yeah, before you actually go into something long term with them. We look at the financial compatibility as well. But all that put aside, there's something we usually ignore, and that is the healthy compatibility. Are you actually health-wise, are you compatible with this person that you're getting engaged with? And that is going to be the focus of our discussion today. Just to let you know, guys, this report is a bit old, 2016. I think that's around 9 years back. We used to have, okay, we had 20,000 children born with sickle cell disease in Uganda, and nearly half of these die before they make their 50th birthday. So that's actually a very traumatizing statistic when you look at it, because it means, I mean, why should we have 20,000 children born with sickle cell? Sickle cell is a disease that is actually avoidable if you are informed and you make rational decisions. And even if they're actually born with sickle cell, why should 50% die before they make their 50th birthday? And a number of couples are actually suffering with recurrent miscarriages. They can't hold pregnancies just because of things like rhesus incompatibility. As we get along, we shall get to understand what rhesus is and what it means. But yeah, we have couples where they can't have children, and it's literally because they are incompatible. Now, leave alone those conditions. Let's look at the infections, for example. Why should we be having 1.4 million people living with HIV, and why should we be getting 52,000 new infections every year? That is literally 1,000 new infections weekly. Like, why should we have 1,000 new people getting infected with HIV every week? And like I said, most of the pregnancies are unplanned. So in Uganda in 2021, 46% of these pregnancies were actually unintended, and by the way, 60% of these were teenage years, that is 15 to 19 years of age. Yes, so having given you that background, I want us to understand now what these two words mean. When you hear about the word premarital screening, and basically premarital screening is a process where you're getting to ascertain your condition health-wise and see if you're compatible with the person that you're getting involved with. So it's basically an assessment through which couples, they are screened for different conditions, genetic conditions, blood conditions, infectious conditions, and even chronic conditions, so that we minimize the risk of transmitting any diseases to their partners, but also to their children. I don't know if you see. It's actually very cost effective because you do the tests once, rule out a few things, and then you can end up, you can go in with whatever you're planning to do. However, if you do not do this, the long-term implication could be financially devastating. Uh, Take for instance, you have a baby who is born with sickle cell disease. I bet most of you have not seen those children, but it is never a pleasant experience for those mothers that I've seen when they come to our units. And this is actually a recommendation by the World Health Organization that before couples get involved, they should be able to at least do the screening tests. And then premarital counseling. Now these two look like they are similar. When you look at the screening and the counseling, they look similar, but the difference here is in the screening you're actually doing the actual maybe testing, maybe examination. Now in the counseling, you're helping the couple that is intending to get married in solving decisional problems. Okay, so they want to make some decisions. The first decision have maybe getting married. The second decision having children. But you have to help them in making those decisions so that they do not make mistakes they're going to regret in life. This one, we can integrate it with the genetic counseling, whereby you're helping individuals or couples understand and adapt to genetic conditions in order to promote informed reproductive choices and, of course, reduce the incidence of inherited disorders. So the genetic counseling, you're actually going to assess this person and then see, for example, if I come from a family where we have, I'm going to use sickle cell so much because it's the most common condition here. If you come from a family, if I come from a family where we have sickle cell, maybe that means I could be having a trait, and then the woman that I want to marry is also coming from a family where okay, you can do this. Maybe the woman I'm going to marry is coming from a family where they're also having a sickle cell disease. It might not be that person having the disease, but it's there in the family. There's actually a risk of us having a baby who could maybe having sickle cell disease. Yeah, so in the genetic counseling, we are going to have a discussion and see the likelihood of us having a baby who actually has sickle cell disease, and we're going to guide us on how best to go about it. Okay, so if we decide to continue with our relationship, we shall know, and in case we get that baby, we won't have any regrets because we went in for it when we know what we want. Yes, so it is interactive, collaborative, respectful, and of course client or couple centered. Like the couple has the autonomy and they have the right to make a decision regarding the final step that they are taking. So moving forward, why is premarital screening or counseling important? Yes, so of course, to make an informed decision, like I've said about life goals, to avoid any regrets later. And you want to reduce the incidence of genetic or hereditary and infectious disorders. Things like syphilis, things like HIV, hepatitis B, hepatitis C, among other infections. You also want to reduce the financial, emotional, and social burden. Okay, let me repeat those three words: financial, emotional, and social burden in treatment of affected individuals or families. Because, like I said, if you're going to have a child who is having a genetic condition, most times it is financially draining. let alone being emotionally draining. And of course, you want comprehensive, healthy families and communities. So, who and where? Who does genetic screening? Who does genetic counseling? And where can they go? I mean, any couple that is seeking to get married or have children should visit a qualified health worker. There are facilities where they're actually providing like packages to this, but in case you can't have access to such facilities, you can visit a qualified health worker. People like William, they can be able to help you in making this decision. Uh, so what are the components of genetic counseling? One, it involves information gathering. So you want to take some bit of history, both family and medical history, and then you're going to do risk assessment. Here you're assessing the likelihood of passing on conditions. You're going to look at education. So we're going to educate you, explain to you how inheritance works, and then the testing options that are available, and then the support, which is emotional, ethical, and social, and of course decision making. After going through all that process, you will need to make a decision. But counseling, genetic counseling can be done before pregnancy, that is before you conceive, during pregnancy, during childhood, and during adulthood, depending on how the process, how life takes you. So during counseling, the qualified health worker or the counselor will provide you with information on natural history of any medical condition. By natural history, I mean how the disease progresses. That is, most times, if you do not actually seek treatment, they'll provide you with any drugs, information on any drugs or treatment that is available, and then perhaps use of drugs for symptoms control and risk of transmission to the future offsprings if you're having any condition that is actually inheritable. So some of the conditions that we consider during premarital screening and the counseling, we look at genetic disorders. There are very many that we look at. I just give a few examples here. Things like sickle cell, things like thalassemias. Thalassemias, they are more like sickle cell because they also involve an abnormality in formation of hemoglobin. Things like cystic fibrosis, you guys might not understand some of these things who are not people who are not medics, but yeah, this is a condition that may still affect the respiratory system, whereby there's a lot of mucus that is being produced and it causes breathing difficulties among many other things. That's the picture I gave on that slide. And then we're going to look at blood group and rhesus factor. Now, you might not understand what rhesus factor is. I don't know. I'm seated here with someone and she was telling me she's blood group O positive, right? Yes, and I'm also blood group O positive. So this simply means we are actually compatible when it comes to blood grouping and maybe research factor. But you guys know about blood group A, B, AB, and then O. And then you've heard about A positive, A negative, or A minus, B plus, B minus, O positive, O minus. So that minus or the plus is what represents the rhesus factor. Okay, so there is what we call the rhesus antigen, which plays a very important role in the body. So where someone has that rhesus factor, they are given a plus on their blood group, and where they don't have it, they are given a minus. So if, for example, a woman is blood group O minus, and the man is blood group O positive, this man has the rhesus antigen, the woman does not have it. If the two meet and maybe they are engaged in the process of having a child, this woman's body is going to receive this rhesus antigen and it's going to be sensitized to be like a foreign particle coming in. So it's going to produce antibodies to fight this foreign particle that is coming in. And most times on the first pregnancy, they're actually able to carry the pregnancy to term and they give the baby, they get the baby. But in subsequent pregnancies, we tend to have miscarriages because every time this woman gets pregnant, because the body was sensitized, um, these antibodies keep fighting this baby that has been formed in the uterus. That's why sometimes, if the couple was incompatible, there are some drugs we usually give to actually try and counteract the effect of these antibodies. You hear about things, we have known about things like is it anti-D, yes, injections that they can give to someone who has just had a miscarriage, and then during pregnancy, maybe after pregnancy. But also, apart from causing miscarriages, even the baby who is born can have things like maybe hemolysis, where blood cells just keep breaking down on their own, the red blood cells. So that's why it is important to do such tests and make sure that we are actually compatible. And if you're not, like I said, we can. It doesn't mean that you're going to break up automatically, but we can have alternatives. Then people who have had recurrent miscarriages, still we need to know about that history, because you could find maybe they're having chromosome abnormalities, they're having, I've talked about the resource incompatibility and many other things. History of any child defects at birth. So a baby is born with some defects. There's some defects which are actually genetical and can be transmitted. But the others that just come in because of our recklessness during pregnancy, maybe you're drinking alcohol, you're smoking. The others that just come in because nature was against you. And then we also look at now the infections like HIV, hepatitis B, other STIs like syphilis, gonorrhea, chlamydia, hepatitis C. But then I recommend doing a mental health assessment. You need to know the person that you're going in with. You don't want to be with someone who's going to kill you in the middle of the night just because you did something small to annoy them. And some people do fertility tests, but these are optional. But I would recommend doing a fertility test to see if you actually you're okay, and if you're not, we can always try to manage accordingly. And most times, chronic conditions like DM, hypertension can also be screened for. So the steps that are involved include, of course, the biodata, that is getting to know who the person is, the name, age, address. These things are actually important, one for identification, but also when you look at things like age, there are some things we're able to assess just based on someone's age, because not every illness will be evident at every age. So some diseases come or become more prominent at different ages. Then we shall take your history. Now in the history, I want to mostly focus on the family history. I want to see if in your lineage or from your grandmother, grandfather, they had any issues, they had any chronic illnesses, they had any of those genetical illnesses, anything that you could know about. I don't know if they did, but yeah, we want to know about that. And of course, on both sides, both the man and the woman. And you also want to get your current personal history. See, in case you're having a condition which can be passed over to your children. And then we shall do examination, we shall do investigations, discuss the results with you, and then make a decision. So in history taking, I think I've talked about this already. Any other complaints, chronic conditions that are known, previous blood transfusions, if you've been married before, if you gave any birth, if there were any issues with the children, and then history of previous struggles with fertility and family history. Examination, you're going to look at the vital signs. That is things like blood pressure, pulse, temperature, respiratory rate, among other things. And of course, you're going to do systemic examinations, looking at the cardiovascular, the heart, the vessels, looking at the respiratory, the abdominal, the central nervous system, trying to assess quite a number of things. And then the investigations that are commonly done in Uganda, basically these are the most common ones, but what I can say is that there are more that can be done, at least in the advanced countries or the developed countries, they are doing far more than what we are seeing here. But things like sickle cell screening tests, blood grouping, and research factor, I've talked about them, those two. CBC is a complete blood count. It's a screening test that we use to look at your white blood cells, your red blood cells, and your platelets. It can also be a very important informative test. Then HIV testing, hepatitis B, C. I've talked about these things. Urinary cysts. This is testing for STIs, vaginal swab, syphilis test, fertility tests can be done, ultrasound, and many other tests as necessary. I've given you an example here. Can go. So a couple is actually found to be carriers of a sickle cell trait. This is the example I'm giving. Now, what are carriers? A carrier is someone who is carrying. Are you for real? You guys, I'm literally 16 slides ahead of you. Why was no one saying anything? William. Okay. Okay, I think maybe when I put in the presentation view, that's why it disappeared. But are you okay there? Okay. Okay, that is bad because there was literally a lot of illustrations on the previous slides, and I thought you were picking. But anyway, as long as you are getting the information. So I was on this. I was giving a case scenario or an example whereby I come with my woman, God forbid, and we are both found to be carriers. Now, a carrier is someone who is carrying a trait or is carrying part of, let me say, in simple terms, a gene that can actually cause sickle cell, but themselves they do not have the disease. Okay, so the way this sickle cell is actually the way sickle cell is transmitted or it is inherited, we call it recessive. Recessive means, okay, you know, in inheritance there are two things. There's what we call dominant and recessive. Now, a dominant, though you hear the word dominant, it means if it is there, even if it's one, it is enough to cause the physical manifestations. So, in every gene, there are like two. How do they call them? Chromosomes? Eh? There are two alleles. Yes, there are two alleles in each. Okay, in this gene. So, the way you're seeing on this picture, we have the. Let me use this one, the blue and the blue. So the blue represents the normal hemoglobin, the red represents the abnormal hemoglobin, or the one that is responsible for sickle cell disease. So in people who have blue and blue, those are people who are actually normal, they do not have the sickle cell trait. People who have the blue and the red, they are actually carriers. They have the allele that can cause a sickle cell disease, but because there is a normal allele or a normal gene which is dominant, it is it is shadowing the other one, or it is overshadowing the other one. So the other one, which is recessive, can't manifest physically. So looking at this person physically, they would actually look normal, but when they're having that trait or that they are carrying that allele or that gene, okay. So if the two meet, okay, they can actually have, there are four possibilities of the children they will have. The children can either be normal, that is, they don't have any sickle cell trait. So this, I hope you are seeing my cursor. Let me use. Hope you're seeing my cursor. This blue and this blue can come together to give us blue blue, which is now a normal person. They do not have any. They are not carriers. They do not have any allele for sickle cell. And then this blue from the man can meet with a red from a woman, and they give us a baby here who is also a carrier. This red from a man can meet with a blue from a woman, and they give us another baby who is also a carrier. And this red from a man can meet with a red from a woman, and they give us now a child who is having only the bad ones, the bad alleles. And this is a baby who will be born with sickle cell disease and sickle cell anemia. Okay, yeah, so when you look at this, that means for a couple where the two are carriers, there's actually a 25% chance of having a baby who is born with sickle cell disease. However, if one person is a carrier and the other one is normal, does not, let me say the man did not have the allele or the gene for sickle cell and was also blue blue, the woman is blue and red, these people will not have any baby who has sickle cell disease, but they will have some carriers among those babies. If the woman was red red and the man is blue blue, they will actually have only carriers. There won't be anyone who is sick. But if the woman was red red and the man is red blue, then is it like half of the babies born would actually have the disease? Yes. So that's why it is very important. Now, when you look at this, 25% looks like a very small percentage, but I can assure you that we've seen couples where their firstborn is a sickler, the secondborn is a sickler, the thirdborn is a sickler. So after all this, we shall tell you what happens when a baby is born with sickle cell. Still on our example, this baby is going to be in pain for most of their life. Like, they literally be in pain most of their life, and you're going to spend most of your time in hospitals. I don't know if any of us would wish for that. These children are going to be anemic. Their red blood cells are actually breaking, what we call hemolysis. So they keep breaking and breaking down, and they're going to be anemic most of the time. And when they break down, they release some chemicals. That's why we see they have yellow eyes, because what we call jaundice. Okay, the hemoglobin is being broken down, and then most of their blood cells will move into the spleen. Of course, that's why they have spleen kekatago mu Luganda. I don't know how they call it in your language, the Rotoro, but yes. So they will always be anemic, of course. Now they will keep getting infections, recurrent infections. So most times we keep them on antibiotics for prophylaxis to prevent these infections. Most times they're actually retarded, so they have growth retardation, they are underweight, okay, they have delayed sexual maturity. Sometimes they experience acute chest syndrome where they literally almost die from respiratory complications. There's a very high risk for stroke, a risk for pulmonary hypertension, and many other things. So after taking you through all those those possibilities, we shall give you the options. So either we explore the option of IVF, because with IVF we are able to screen and actually have a baby who is not sick, but IVF is very expensive. Yes, IVF is ranges between 15 million if you're doing it from Lago to around 35 million if you're doing it uh, from yes, there's a hospital in Bukoto, International Women Fertility Center, something. It's around 35 million. And one thing with IVF is that you can do one cycle and it fails. So that money is gone, you go for another cycle. We can also tell you to actually do adoption. Maybe if you guys can't separate, maybe you still want to be together, you can do adoption. Instead of having a sickler, you can just let natural conception take place. But I'm calling it here informed natural conception, so you know what you're going into. In case anything happens, you won't have anyone to blame. And lastly, we can just counsel you that you know what, you love your partner so much, but from what we've seen, I think you need to just still remain very good friends, but look for other partners. I hope I'm still being heard, and the slides are still visible. William, confirm that. William, please confirm. Okay. Now, there are some things that are important as considerations here. I'll bring the questions up last. There are ethical, cultural, and religious considerations. One is respect for autonomy. So it's the couple to make the decision. For us as doctors, as health workers, our work is to give you information. So it's you to make the decision. There's also a risk for stigma and discrimination. So some people who are maybe having, let me say someone is a carrier, they might feel discriminated when you actually tell them to break up with their partner just because of that. They didn't choose it, I mean. Sometimes maybe someone is a sickler and they feel like you're stigmatizing them. So that's also something that concerns us. And then, of course, acceptance varies by culture and religion. I know some people who will be like, for me, for us, God brought us together and no one can separate us, not even the disease, just because of what they believe in. And others, of course, their cultural beliefs. So that can also affect the decision making. But as a counselor, your work is to remain neutral, supportive, and of course confidential. Like I've said, some of the challenges we face is stigma and discrimination, and then lack of awareness and misconceptions. Like we've seen, sickle cell is actually avoidable. But why should we continue having very high increase in the number of sicklers that are born every day to something that we can prevent? This is particularly mostly because most people are actually not aware about what they're supposed to do. Like I said, most people just have cold weather babies. Okay, they have not actually planned for them just because it was cold, and she passed by. Things happened, and yeah, of course, the cost can be high sometimes for some people. There are some screening tests, for example, for sickle cell, which could cost around 30,000. But also there are others, like the one I did myself, which is HB electrophoresis, which can go up to around maybe like 65, 70. And then, of course, shortage of trained counselors and testing centers, and then the culture and religious resistance. So this is not just for healthcare providers, but for all of us. If we could, yes, as you're seeing in that picture, if we could engage in campaigns that are aimed at at reducing these genetic conditions by promoting premarital screening and counseling, we would do better through raising awareness, through education, providing counseling, advocate for supportive policies, offer psychosocial support, and of course collaborate with leaders for wide acceptance. This goes to cultural leaders, religious leaders. I mean, the pastors should take lead in telling their sheep to go and do these screening tests before they actually get married in church. Yeah, so in conclusion, we discussed a lot, but genetic counseling plus premarital screening is equivalent to healthier families. Early testing prevents disorders and supports choices, and it requires collaboration among health workers, policymakers, and the communities, and of course everyone else on this call. So thank you very much for listening and for being a very attentive audience. I hope I've used my time well. I've used like 40 minutes. At this time I'll take in any questions, and I hand over back to the moderator. Thank you.